All right. Hello, everyone. This is Vignesh Ganapathy with the Every Life Foundation and Rare Disease Legislative Advocates. Thank you for joining us today for our September legislative meeting. It's a little bit of a different time that we're hosting it, but hopefully, you were able to find some time out of your day to join us, and thank you. So we have a fairly short agenda. We're going to start out with a discussion of H.R. 3742, the Access to Marketplace Insurance Act. We have Kyle Rosner, who's a Government Relations Associate for Patient Services Incorporated, here with us in D.C. And then Brett Copeland, I hope I got that right, with the Executive Director of DEBRA of America, will be presenting on the PRV, Pediatric Review Voucher Program. I'll give an update on SB 1095, the Every Life Foundation's newborn screening legislation in California. And finally, my colleague Max Bronstein will give an update on the work that the Foundation is doing on Capitol Hill. So to get things started, I will pass it off to Kyle.
Thank you, Vignesh, and thank you, everyone. Like Vignesh said, I'm from Patient Services Incorporated. Just a brief background, we're a nonprofit that accepts private donations into disease-specific funds. We helped about 36,000 Americans last year. We're 27 years old, and let's see where we're at. So, we've been helping people with premium assistance, copay assistance, coinsurance, travel expenses without a hitch until 2014. CMS, the Center for Medicaid and Medicare Services, released an interim final rule regarding insurance providers accepting third-party premium assistance on the new marketplace exchange. And what the rule said was that these insurance providers have to accept third-party premium assistance from state age drug assistance programs to the Ryan-White programs, Indian tribes and tribal organizations, and any other state and federal program. Other than that, and I put the quote at the bottom, they said that, health insurance providers can implement contractual prohibitions on third-party premium assistance. So what that meant is it left out charities, it left out places of worship, it left out, a neighborhood, a community if they wanted to get together. So almost immediately, we started, PSI started receiving notices from these health insurance companies saying we're not going to accept premium assistance from you on behalf of the patients. Since 2014, it's ballooned up to 60 plans of 38 states. And what's really alarming about this, right, this only applies to the marketplace right now. But what's alarming is that insurance companies have been lobbying state insurance commissioners in Idaho and Minnesota. They've actually been successful. These two states have implemented, the similar rule of of allowing insurance carriers to up to their discretion on who they accept it from, but they've implemented the plan for the entire state insurance market. So not only the Obamacare marketplace. So we are really, just from how aggressive it's been in the past 2 years, looking forward, we think it's going to spread and more of these state-type rules are going to pop up. So we're really trying to be aggressive and nipping this in the bud. So CMS, a lot of people when we talk about this, they would say, why would an insurance company ever deny money? That doesn't sound like them. What CMS has claimed and what insurance companies have stood by is that we are going to be skewing these risk pools by influx of really sick patients. First, we've never received any evidence of this from CMS. And PSI has asked, our stakeholders, our patients, and also Congress has sent several letters over asking for the reasoning and any data. They've never provided any reasoning, any data. Just looking at PSI, we helped 36,000 in 2015, and we looked how many of those were marketplace patients, and they were about 500. When you compare that to the state ADAP programs, which the interim final rule mandates insurance carriers have to accept, in 2015, they premium assisted 48,000 patients. So from talking to other premium assistance organizations, theirs are also in the hundreds. So combine that together, we'll charitably put it at 5,000 in 2015. Compare that, with the 48,000, it's just not even in the same ballpark at all. So we're not skewing the risk pools, and we feel, we support the state ADAP programs, of course we do, but we feel that there's some sort of discrimination when they're picking which diseases they have to accept and other ones they don't. So, before I get started on our bill, I'd like to say that, PSI went through the right process. When the rule came out, we did comments on it. We got our patients to do comments on it. We got our stakeholders to do comments. We got Congress to send letters, and CMS has been clear since day one that they're not going to change this. They could change this tomorrow with a rule change. They're not, they haven't. So we spearheaded the effort with H.R. 3742, which is the Access to Marketplace Insurance Act. It was introduced by Congressman Kevin Kramer from North Dakota, and he's been really good about not politicizing the issue. This is a little bit outdated since last week, we now have 112 bipartisan co-sponsors. It's up to 70 Rs and 42 Ds. And, there is a Senate companion in the works, it hasn't dropped yet, and, that's we don't know when that's going to happen. I thought I would include that. But right now our priority is to get as many co-sponsors as possible with the hopes that CMS will see this and realize that, it would just be easier for them to change it, which they could at any moment's notice. So, right now there's 500 patients affected by this, but it's growing each year. And like I said, they're starting in Minnesota and Idaho, they implemented it to the entire insurance, every market, if you're employer, individual, whatever it may be. And we like to say, well, if we're not here, we're here as a safety net, these patient assistance programs. If it's not for us, then patients are faced with some tough choices. They have to spend down to qualify for Medicaid. That's not easy. You have to divest yourself of interest and of assets. You could wait at least 24 months to qualify for disability. That's at least 24 months, and those are a long 2 years. And so what are you supposed to do in the meantime? They could go back to utilizing the emergency rooms. The Affordable Care Act was supposed to solve this. We feel this rule has created a loophole. They left it up to the insurance companies to decide on their discretion who they're going to accept third-party premium assistance for. So if you're perfectly healthy, they might not care. But if you have a chronic and costly illness, they're not going to accept it with the hopes that they're going to price you off the plan. In some states that haven't expanded Medicaid, and it's a much tougher time, or they may just forego the care completely because it's such an issue. So we also have we put together a coalition, and you can see the members here at the bottom, and it's called the Marketplace Access Project, and it's a patient advocacy movement, and it's dedicated to protecting what nonprofit insurance premium assistance organizations do for patients. And we are always looking to expand this because the more voices, the more chance we have to change this. And what folks can do, they can join MAP. Your organization could join. That would be huge for us. Also, using any congressional contacts and asking your members to co-sponsor H.R. 3742, bipartisan. We're just trying to make sure charities can be charitable. Placing the bill on your organization's legislative agenda, obviously by joining MAP, that would do that. That would be huge. And partnering with MAP to bring patients to D.C. So yesterday we were up here for Scleroderma Foundation. They had their Hill Day, and it was on their agenda. And we, using their organization, by them putting their voice to it, that was huge. So any help would be amazing to ensuring that patients have access. We don't want to see families bankrupt themselves just trying to find affordable health coverage. So thank you. This is my contact information. If you have any further questions, you can contact me whenever you like. Thank you again.
Of course. Thank you, Kyle. We usually do a question and answer. Oh, question period. So I can, if you don't mind, I'll open up the lines right now. Give me just a moment.
Let me ask you what I just raised to Jim. How does the non-discrimination clause of the Affordable Care Act have an impact on that? Because this is clearly discriminatory.
Right.
Well, we placed that in a comment that, and I know other groups other nonprofits are using that in their comments too, that, pointing out this language. We've shared it with the White House. So there has been no response, but I always said we could sue them. I don't know if they have the resources to do that.
Does anyone else have any questions for Kyle?
This is Teresa Barnes. I do actually a comment mostly, but a question. I definitely think we should, I didn't know about. I knew about the PSI effort back a while back when the proposed rule came out, but I didn't know what the process was at this point. So I'm really disappointed to see that it still has not moved, and that Medicare and Medicaid has not done anything to change their mind, which is completely another story. But in my patient population, my patients live less than 3 years. So for them to have to wait 2 years for any help is, literally, they will die in the time that it takes to get Medicare to kick in. So the help that they've gotten in the past from organizations like yours has literally saved them. The disease, unfortunately, is not curable, but it does save them by providing some semblance of palliative or some other type of care. So this is a huge issue, and I want to do everything I can to help you, and I think all of us should want to do that. And it also seems like that this is a bit of a slippery slope, that once nonprofits of any kind are prevented from doing what they do, which is help patients, then that's a huge, I think we all need to be concerned, because that red flag to me is not about providing premiums for patients, but it's providing help for patients.
Right, yeah, and I appreciate your comments, Teresa. What organization are you with?
I'm actually an independent advocate in lung disease. I work in fibrotic lung disease mainly.
Okay. Yeah. This is like you hit the nail on the head. This is a huge issue, and it definitely is opening the door to the insurance companies putting this forward. Yeah, and I'll reach out to you, and if you need any more information for it.
That would be great. And Max has my information. That'd be great. Thank you.
Yes.
Thank you, Teresa. If there aren't any other questions, or if you have any other questions, you can feel free to contact Kyle. His contact information is right up there on the screen. And with that, we'll move on to Brett Copeland with Deborah, who will be presenting on the Pediatric Review Voucher Program. And I will pass over access in just a moment. Brett, are you there?
I am. Am I muted or unmuted now?
You are unmuted, so we can all hear you loud and clear. And
okay.
There you go.
Take control. Got it. Okay, let me just see how to do this. Okay. Whoa, that's you have a different one on there.
Oh, is this a different?
Yeah, this was from the Rare Disease Week.
Oh, this is the one that I received from you.
Oh, shoot. Do you want to just share my screen? Because I have this one here.
I'm not sure whether I have access to get your screen up. What we can do is we can.
Why don't I just talk through it, without slides up, if that's okay. It'd probably be the easiest way.
Sure.
So thank you for inviting me. My name is Brett Copeland. I'm the Executive Director of DEBRA of America. DEBRA is an acronym for Dystrophic Epidermolysis Bullosa Research Association. And I'm here to talk about the Rare Pediatric Disease Priority Review Voucher Program. it is a somewhat complex situation that, given the time constraints that we have, I haven't done a completely deep dive here, but I wanted to give a little bit of history of it, let you know what type of incentive it is, and let you know that it is supposed to expire on September 30th. So we're certainly hoping that Senate comes around with the Innovations Act that would allow it to continue. It is still a new incentive, so whether or not it can be truly considered successful is yet to be seen, but I don't see any reason why it wouldn't be. Incentives are quite successful. For instance, if you look at, this public-private partnership really started, I guess, in earnest back in 1984 with the passing of the Orphan Drug Act, which has had some pretty significant implications for drug development, and it's helped a lot. So if you think in 1983 and 1984, there were 5 drugs approved for rare diseases. In 2014, there were 49 so-called orphan drugs approved. And in total, from 85 to 14, the FDA has approved 511 orphan drugs. But here's the better part of that incentive. They've granted orphan drug designation to 3,280 drugs, have received 4,738 requests for designation, and that number is growing 30% year over year. So we're going to be hitting new records each year. So it's a proven incentive on that. So well, before I go even further, I want to tell you a little bit about what EB is. We call it EB, epidermolysis bullosa. It's been called a skin disease because its hallmark symptom is extremely fragile skin that blisters and tears with any sort of friction or trauma. It's been called a group of disorders because there are 5 types and 31 subtypes, yet but neither properly really defines a disease. We call it a rare genetic connective tissue disorder. We call it the worst disease you never heard of, and that has many genetic and symptomatic variations of EB, but they all share that prominent symptom of extremely fragile skin. There's about 25,000 in the U.S. that live with it. It affects 1 out of 20,000 live births, which is about 200 kids a year, and they're called butterfly children. Some interesting numbers is 1 out of every 227 people has a defective gene that causes one type of EB or another, and there's about 500,000 worldwide. So now a little history on, going back to this incentive of the Rare Pediatric Disease Priority Review Voucher Program. Back, if I'm talking too quickly, please let me know. Back in 2007, Senator Sam Brownback had created a voucher program as part of the Food and Drug Administrative Amendments Act. At that point, it was to provide a voucher and priority review for tropical diseases that was to incentivize drug development for unmet diseases like malaria and dengue. And then as they showed that was successful, in 2012, the Rare Pediatric Disease Priority Review Voucher was created under FDASIA, which is the Food and Drug Administration Safety and Innovation Act. In this case, the rules were that the drug or biologic had to prevent or treat a rare pediatric disease. The drug or biologic can't contain any active ingredient, including the ester or salt of the active ingredient, previously approved in any drug or biologic. And the rare pediatric disease application must be eligible for a priority review, which means that an application for a drug that treats a serious condition and, if approved, would provide a significant improvement in safety or effectiveness, and rely on clinical data from studies looking at pediatric populations and dosages. So that's pretty much the history of it. It was created in 2012, and in that act, in FDASIA, Section 908 added Section 529 to the Federal Food, Drug, and Cosmetic Act, which can award a priority review voucher to sponsors of some rare pediatric disease product applications that meet very specific criteria. Now, this is going to be a very quick overview of this. People realized that there needed to be another incentive because a lot of these rare diseases were affected pediatrics more than not. So, and they were unmet clearly. So, according to the FDA, a drug that would qualify as a drug for a rare pediatric disease if the entire prevalence of the disease in the U.S. is below 200,000, and if more than 50% of the patients with the disease are 0 through 18 years of age. And the drug must also qualify if it is an orphan subset of a disease that affects 200,000 or more persons in the U.S., and if this subset is primarily comprised, aka more than 50%, of individuals aged 0 through 18 years. So in EB, the majority can actually live a normal lifespan, but in a type called dystrophic and recessive dystrophic, which would be a subset of that, more than 50% of the individuals are aged 0 to 18, and most actually, unfortunately, lose their battle in their third decade. Be lucky if they live to 30. So in this case, EB does actually qualify, or drugs looking to treat those with dystrophic. It does qualify. So what actually is it, and what incentive does it provide? The sponsor that develops one and applies for one has a choice that they can make if awarded. One, they can obtain priority review of a drug application, which means the FDA would respond within 6 months instead of the customary 10-month period. It is not a promise that they will do it within 6 months, but it is a guideline. And the review does not mean approval. It's pretty important to know, and as we'll see, there's one of the priority review vouchers for a tropical disease that was used actually ended up in not being approved. Now, the other option that they can do is the sponsor can sell the voucher right now, and that's actually a pretty big incentive. The going rate right now is about $350 million, and then that voucher can be resold any number of times. So either way, depending on pricing models and everything else, if you get to market faster, 4 months faster, one, you get first mover advantage if other drugs are being developed. If not, you have, longer patent protection, certainly, and it's greater access for the patient population in a much faster time. So there is that, or the ability to sell it, which are, pretty big incentives. So up till today, there have been 6 vouchers that have been awarded, and actually 2 have been used to date. Originally, BioMarin was awarded one, which they sold to Sanofi and Regeneron for $67 million. That voucher was then used successfully to speed the approval of a statin therapy. United Therapeutics sold one to AbbVie for $350 million, which has not been used yet. Asclepion Pharma, if I pronounced that wrong, sorry, transferred to Retrofin and then sold to Sanofi for $245 million. Sanofi redeemed the voucher for a type 2 diabetes drug. Wellstat Therapeutics transferred it to AstraZeneca, and Alexion Pharmaceuticals has 2 vouchers, and both are unused. So the numbers are small, but given that this was really just brought in 2012, we've got a few, I would say a good decade to go before we can really evaluate just how successful an incentive like this is. Like I said earlier, there's no reason to believe that it wouldn't be successful as an incentive. Now, think if the sponsor was to sell their voucher, and the cost of drug development being so high, they could recoup some of that cost, which they could put into further therapy, into patient services, into acquisitions for other rare diseases. So I do think it's going to be proven to be a very strong incentive. So what I've done, and unfortunately haven't been able to put up, for a complete understanding of the Rare Pediatric Disease Priority Review Voucher Program, it's best to refer to the guidance for industry released by the FDA on November 17th, 2014. And I actually have the link from the FDA.gov site that has about a 40-page discussion on how to apply for it, what the usage fees are, what all the rules and regulations are around it. Like I said, I just really wanted to give a slight history, what it was, and how many have been done. So I thank you for the time. I hope I didn't talk too quickly, and you know, you can, Max and everyone has my contact information, so should you have any more questions or want to discuss it further, please don't hesitate.
And sorry. All right, Brett, do you mind staying on the line a moment while I open the lines and see if there's any questions for you?
No, of course.
If anyone has any questions for Brett, feel free to ask now, or you can enter any questions in the chat box.
Better mess with it because we'll lose it. There, yeah, they just too bad. We weren't able to.
Looks like we've got someone in a different conversation on the line.
Hey, Brett, it's Michael Loso.
Hey, Michael, how are you?
I was wondering where things stand on the Hill. Is there opposition to it being renewed, or is it just kind of lost in what's going on?
Well, I generally think in our political environment right now, there's opposition to the wind blowing. So I wouldn't. It's hard to have total opposition. There is criticism of these type of incentive programs out there, like it's a gift to industry. You know, that there's nothing stopping, you know, a diabetes drug or, you know, a statin therapy from getting a priority review because of the selling. But you know, right now it is part of the Innovations Act, which, from my understanding, is getting some. You know, it's a big question mark if it's going to get passed, and it needs to happen before September 30th. Otherwise, this incentive is going to expire.
Mm-hmm. Thanks.
Does anyone else have?
I will say. I'm sorry, Michael, I will say one other thing, that there has been some push to pull this out of the innovations package, the Innovations Act, and have it voted on separately. I don't think that is the best way to go, because there are so many other aspects of the Innovations Act that are incredibly important to rare diseases in general. But, you know, again, incentives do work. So we'll see how that goes in the next few weeks.
Mm-hmm.
All right. If there aren't any other questions, you can feel free to contact me, or and I can forward questions along to Brett. Or Brett, if you have an email address you'd like to share, I can make sure to follow up with that.
It's my email address is very simple. It's Brett, B-R-E-T-T, at Debra, D-E-B-R-A.org.
Great. Thank you, Brett. All right, and I will remute the lines and give an update on the Every Life Foundation's newborn screening efforts in California now. So for those of you who are not familiar or who haven't been following our legislative webinars each month, actually, hold on just one moment. Looks like Stephanie Bozarth has a question for you, Brett. If you're still there.
I am still here.
She's asking, what can advocates do right now in September? Is there an active action alert?
Yeah, I'm sure RDLA will probably have a something up where they get a letter. I mean, clearly the best thing to do is write letters to everyone and anyone at this point. It's very right now. You've got about 2 weeks to really put a lot of pressure on our local senators to move forward on this.
So this is Max. Following Viggie's presentation, I'll be giving a Capitol Hill update in which, among other things, I will outline an action alert for folks to get in the fight here. So stay tuned.
Great.
All right. So for those of you who have not been following the Every Life Foundation's efforts in newborn screening, I'll give a short background on the state of newborn screening in this country, and then the way in which we're looking to improve the system. So currently, the newborn screening system is a patchwork of different state requirements. So while some states screen for as few as 21 diseases, others screen for upwards of 56. And as a result, babies born across the country are falling through the gaps, and they are not diagnosed early, and they are not treated at the earliest sign of symptoms. So, of course, newborn screening is vital to ensure that we can get that early diagnosis and treatment to these babies. So we have been working to launch legislation in California to require the state to screen for all diseases on the RUSP, the Recommended Uniform Screening Panel. So to give some background on the RUSP, this Recommended Uniform Screening Panel is issued by the Secretary of Health and Human Services after a long consult with an advisory committee on heritable disorders in newborns and children. The basically the patient organizations and anyone who's interested can nominate a disease, which is then considered by the committee. The committee then does a thorough scientific and economic analysis before making a recommendation for addition to the Secretary of HHS. And then if it's accepted, the disease is added to the Recommended Uniform Screening Panel. So on average, it takes about 4 years to add a disease to the RUSP. Some take much more, and some don't take that long at all, but regardless, the process is incredibly thorough. States, however, since these requirements are not binding, states can take up to 8 years following that to actually begin those screens. So in those 12 years, you can only imagine how many children are falling through the cracks and are not diagnosed early. California was a logical place to start because the state screens for 540,000 newborns each year, which is the most in the country. For all but 2 of the RUSP conditions, those are Pompe and MPS I. Both of these diseases have had FDA-approved therapies for over a decade, and the state has 5 public health laboratories that are using tandem mass spectrometry of dried blood spots to do analysis. And finally, the most recent bill that was passed in California to expand the state newborn screening program was for ALD, and the bill required that as soon as ALD was added to the RUSP, that the state would screen for it, as it just was this past year. So this bill, SB 1095, was introduced by State Senator Richard Pan, who is a pediatrician, and he has authored that life-saving ALD legislation, as well as previous SCID newborn screening legislation, both of which were signed into law. And this bill would allow the state to screen for a disease on the RUSP within 2 years after the disease is added to the panel. It would eliminate any unnecessary legislative delay in screening. Those 8 years, for example, are now shortened to a maximum of 2. And it also ensures that there's no need to pass new legislation for every disease that the state may consider screening for. And of course, it would allow for the earliest treatment possible. So we have some great pieces of news. SB 1095 passed every committee that it was heard in and both houses of the California State Legislature unanimously. Advocates from across California came and testified, along with some from outside of the state, as are shown in these pictures here. And it was with some very moving testimony, the bill sailed through without any significant opposition. However, the Department of Public Health expressed some concern that they'll need time to implement screening and secure funding in the budget. So we worked with the Department of Public Health to craft a workable timeline for screening these new diseases once they're added to the RUSP. What we came to was that California must screen for any disease within 2 years of addition to the RUSP or enrollment of the bill, whichever is later. So this will give the state enough time to secure funding and any new screens or staff or assays that they need to in order to conduct the screens. What this means in practical terms for MPS I and Pompe, which are currently on the RUSP, is that California will have to screen for these diseases by August 26, 2018. The work is already underway, and if this bill is passed, we're confident that they'll be able to they'll start putting in their budget requests and procure whatever equipment they need. Over 120 patient organizations have shown support. Many of you are probably on the call, and we'd really like to thank you for your efforts in this area. And now the bill has headed to the governor's desk, and he has until September 30th to sign or veto the legislation. We met with the governor's office 2 weeks ago, and the prospects look good. But as many people across the country, and especially in California, know, the governor is very concerned about his budget and about finances, so we still have a case to make. So this is the way in which you can help. We encourage you to visit the Every Life website or the shortened link there, bit.ly/supportNBS. And on that page, you can write a letter on your own behalf with your story if you're a patient in California, or if you're an organization from anywhere across the country, you can use our outline to write a letter in support of this bill to the governor. And we've been hand-delivering these letters to the governor's office to ensure that he reads them and gives them due consideration. And lastly, we're also looking for California patients to submit op-eds to us, and we will then shop them around to any newspapers, really just highlighting the need for expanding the state's newborn screening panel and ultimately for the governor to sign SB 1095. So if you have any questions, you can feel free to ask me now. I'll open up the lines. And my contact information is also available right there on the screen. So any questions?
That good, Biggie.
Okay. Well, as you can tell, my information's up there, so feel free to send any emails, and we look forward to receiving letters and any type of support from you all as we can. We're rounding into the final month or final couple of weeks on this, so all of your help is much appreciated. And with that, I will hand it off to my colleague Max, who is here, and he will give an update on the goings-on around Capitol Hill.
Thank you, Biggie. So I'm actually speaking to you live from Washington, D.C. Usually we do these San Francisco and California, but we're in D.C. this week because there's a lot going on. Today we held an RDLA briefing, which Biggie organized, and earlier this week we had a scientific workshop, so there's lots of action, and we should have a lot of news about what's going on Capitol Hill in terms of cures and some other things that we've been following next week. So I'm going to try to give people the background so that if and when we get news, people understand the context for it. So I'll start just kind of with a quick overview about cures, because I know many of you are been following this closely. For some, it might be new, but this is a piece of legislation that started in the E&C, or Energy and Commerce Committee. This actually started early in 2015, so it's been quite a while now, but really Chairman Upton has been a huge sort of force pushing this bill forward, and he partnered with Congresswoman DeGette to make this a very much bipartisan effort. And within that piece of legislation, there were a huge number of provisions of importance to the rare disease community and beyond. I'm going to go kind of quickly through these because there's so much in there. I don't want to take the time to read through each one, but I've underlined the Open Act, which I'll get into in a later slide, but this is something that we think could actually double the number of therapies available to rare disease patients. So I think that deserves an underline. There's also stuff in there about biomarker qualification. We've been working, the foundation has been working for a long time to try to improve and streamline FDA review, and part of that means getting the best possible reviewers in the door there. And there's also provisions in there that would provide substantial funding increases to NIH and FDA. And you can see that there's other areas, too, that are of importance to us and that we want to see passed, including the priority review voucher program, as you just heard about. So this bill is really chock full of things that can have a huge impact for our community. Just to give a little more color about the Open Act, basically this is something that is designed to encourage companies to repurpose drugs that are already on the market for rare disease indications. As folks know, it's very common in the rare disease community for off-label use to occur. This is something where you can actually get off-label use studied, ideally, and actually have some clinical data to know whether or not that off-label use is safe and effective. It would be very valuable information, even if it turns out not to be effective in that rare disease. So assuming that the indication being studied is effective for a rare disease, the company would gain 6 months of additional exclusivity for the full indication. So we think that's a substantial incentive and hopefully enough to get companies more interested in the rare disease space. It's based on a law called the Best Pharmaceuticals for Children Act, has the exact same mechanism as that law, something that when it was passed in 2002 resulted in 400 label changes, which dramatically changed what we know about how drugs work in children. It's very, very important information there, and we've basically used that exact same mechanism for the Open Act, so that's why we think it could double the number of treatments available to rare disease patients. And I should also take a moment to thank the organizations who have signed on in support. We're up to almost 170, so if you guys know of one more, I'd love to get to the 170 number. So thank you so much for all of your support there. I'm not going to talk about this program because this was just covered in the last presentation, but I will mention the final bullet there, the one in red, because Brett mentioned this program is slated to go away on September 30th. And if you heard from Brett, there's a huge amount of value that's been created by this program, and I think that's evident in the dollar figures that he cited when those vouchers are transferred and used. So clearly there's strong incentive there to develop these new therapies. So, we think this is a really vital program, and we want to see it continued. And this sort of brings me to the state of play around cures, which the Open Act has basically been hitched to that wagon, as has the priority review voucher program. So there's still, unfortunately, very big debate about how to fund this legislation. So anytime someone wants to create a new program that requires new funding, the political environment is such that you have to take money from an existing area of government in order to fund it. For short, we call that a pay-for. The pay-fors are still being debated, and this could turn out to be an expensive bill. So we're waiting for Congress to figure out how it's going to fund this and then ideally put forward a deal so that we can get things moving. I've heard that there's a chance that some of the proposals that were in the cancer moonshot coming from the White House could be included in this, which is very smart politically, because in the event that it passes Congress, it would help ensure that the White House would sign off on this as well and really allow it to become law as quickly as possible. But there's some big challenges coming up. We're hearing that the Senate might actually recess early. They are, some of them are very nervous about keeping their jobs, not surprisingly, so they want to have a shorter session so that they can get back home and campaign before the November elections come. So, we have the election coloring things here, then we have the possibility of an early recess, which decreases the amount of time to do legislative business. And then, we have lame duck after that, and historically lame duck is not a period where major legislating gets done. So for all of these reasons, this is why we need to get cures done as soon as possible and in this month before Congress decides to go to recess. So, I talked about the election year. Zika is still an extraordinarily hot topic. There's even a possibility that funding could get looped into cures. So, Congress can pretty much do whatever it wants. It's just a matter of us pushing hard enough and making them understand that this is the highest priority for them to really make things happen. And then the other distraction is not only does the PRV program expire at the end of the month, but the fiscal year ends at that time too, and Congress, true to form, has not figured out how to fund the federal government in the next fiscal year yet. So that also has to be decided, and if it's not decided by the end of the month, it threatens the continued operation of the entire federal government. So no one's anticipating a shutdown, but what the debate is about is the length of a CR, which is short for continuing resolution, which basically means that the government would just hold steady all funding levels from last year if they can't agree on new funding levels. So it seems likely that that's what we'll have. The question is how long that CR will last. So, we're hearing that. We're hearing rumors that there's possibility of a sort of pre-conference version that might be agreeable to both sides coming to the front. We really don't know what's going to happen. I've heard rumors that are kind of contradictory at this point, so rather than report on rumors, I'm hoping that we'll know more and we'll have some more solid information by the end of the week. And so at that point, if there's big news, I will be happy to send that along. So there's a lot of uncertainty out there, but I do want to mention and thank folks who participated in our in-district meetings. So we got the final counts in, and we had 161 meetings taking place across recess, and 40 of those meetings were advocates actually meeting directly with their members. You can see some photos here, and then on top of that, there's been quite a bit of ongoing media coverage about the need for cures and certainly about rare diseases. So that's been very encouraging to see and has helped us keep up the momentum. And this next slide is what I promised to share earlier. We are in the midst of running a social media campaign. This is our action alert. And really what this is about is reminding Congress what's at stake here with cures. So you'll see that all these photos feature kids. This is not meant to be a campaign exclusive to kids, but obviously when you're working with Congress, this is very compelling photos where we're asking folks to pose for a picture, create a sign that has their state in it. That way we can share that information directly with the senators and folks from the House and let them know that this is a priority for their constituents. We set up a special email address so that you can actually directly send your photos to us. We can help you get them posted if you like, or if you're savvy on all the social media stuff, that actually has a link contained in the text there, which will tell you all of the Twitter handles for your senators, and you can also find them for your folks in the House too. So when you post your photos online on Facebook or on Twitter, you can actually tag your senators in it. And we're also asking that folks share the action alert. I'm sure many of you are on the Energy and Commerce mailing list, and just today they shared this action alert with their entire list. So if you want, you're more than welcome to just forward that along to your networks. That's probably the easiest way possible. On the website, we also have a template available. If you're not feeling interested in doing arts and crafts time, you can just print that template out and pose for a quick photo. And then for many of you, I'm sure we'll be at the Global Gene Summit next week. We'll certainly be there in Huntington Beach, and I'll be there with two advocates, Melissa Hogan and Tracy Van Houten, to again try to get the word out and call on patients to take action and really encourage Congress to get this done before it's too late. So that's what's going on cures. I'm going to talk a little bit about what the road ahead might look like in 2017 and potentially beyond. So we're hearing that because of the current election dynamic, there's a chance that the Senate could actually flip to be controlled by the Democrats. And I'm sure all of you have been paying attention to the campaign and hearing that there's a huge amount of concern about pricing, and there's definitely been anti-pharma rhetoric out there. So again, this is why it's so important for cures to get done now, because in the event that the Senate does flip and then this gets pushed to next year, if it happens at all, it would be very difficult to get some of the incentive packages passed through a Congress that is somewhat anti-pharma. So that's, again, yet another reason why we need to be so active this month and really pull out all the stops to make sure this gets done. The other big thing that's going to be on tap for next year is the Padufa Agreement. For those who are not familiar with Padufa, this is the agreement with industry and the FDA that enables the funding of drug review at FDA, and the agreement actually includes many performance goals that the FDA must hit when reviewing applications for companies to market biologics and drugs in the U.S. So extremely important provision. We've seen some indications that the letter includes things that the Every Life Foundation has pushed for, including things like patient engagement, improving guidance around biomarkers, and more on specialization, so trying to get reviewers with very specific expertise in rare diseases in the door at FDA, so that when those drug applications come in, they have the right background to understand all of the science and the techniques that were used in those trials. So that letter actually goes to Congress the 1st of next year, and then September 30th really is kind of a magic date here, but that's September 30th of next year that Congress has to actually sign off and pass the Padufa Agreement. And if they fail to do that in a timely way, that would actually shut down drug review at the FDA. But Congress, true to form, will probably wait till, a week or less before that date for them to pass something, because that's, how Congress seems to operate now. So we have that to look forward to next year. I want to pause for a moment here and offer my email address in case people want to email me questions or comments or other things, and we still have time on the call today if anyone wants to ask a question over the phone, or you can also send me a question using the chat box. So I believe the lines are open now. Okay, stunned silence. I don't know if that's a good sign. Was that a question?
Max, this is Teresa. Do you have any thoughts on if the innovations bill is not finished in September? You may have mentioned this, maybe I blanked, but what about a lame duck session?
Yeah, so historically, lame duck is not a great time to get stuff done. A lot of folks have kind of checked out during that time period. And depending on which way the elections go, there might be hesitation to pass a bill during that time because, quite frankly, if the Dems are able to take control of the Senate, for example, they might want to wait until 2017 when they can craft a bill that's more in line with their priorities. So that's again another reason why I would not count on something happening in lame duck, and would certainly not count on this happening in 2017. And I think right now our community needs to focus on September, on this month, and making sure that this gets done before Congress goes home to try to save their seats, because this is the highest priority for us, and it should be for rare disease patients too. Any other questions? Okay, well, if folks think of any other questions, feel free to shoot me an email. I will turn it back over to Vicky to close out the call.
All right, thank you everyone for joining today. It's a little bit of a different time, but we'll be back next month, same time on October 26th at 1 p.m. Eastern, 10 a.m. Pacific. Again, if anyone has any agenda items they'd like to hear heard on these RDLA calls, you can send them over to me. My contact information is on the screen, and thanks again. Have a good day.
Update means what that guy's on over.
Okay.
In fact, that they were up to 112 co-sponsors.
Okay, that was the only.
That was, yeah. I mean, that's the only. Yeah, there's no.